Hey there, we're back, and this time let's talk about two important topics that are crucial for scaling and automating interoperability, the patient ID and the related patient matching. So for many of us in the healthcare industry, these two topics are familiar as we often deal with patient IDs. It may be an assigned ID by a health plan or possibly a Medicare ID, but often we need to go and look at patients' other attributes such as name, gender, and date of birth to really determine who that actual patient is. So as usual, Michael is with me. Michael, so when we talk about patient ID, why is it important to interoperability?
Well, interoperability, especially in the top use cases, we're usually dealing with information that is requested and or sent for a specific patient. So two key conditions need to be met for that to really work. One, you need to obviously request and find the data or return the data for the appropriate patient. The alternative is you get no data or you get potentially even wrong data, which in many scenarios is a nuisance from an administrator's perspective, but in other cases, having not the right data may actually be jeopardizing somebody's health or life even, for that matter. The other side of that, of course, is HIPAA, where we should not and cannot and are not allowed to share data that is not requested or we're not authorized to share. So if in doubt from that perspective, don't share data. So for interoperability to work, we both really need to meet both conditions, which means we need a good match.
Yeah, so that's sort of common sense, and one might think that a standard ID like a social security number would do the job just fine, but that's not the case. So why is that?
Well, I think social security number has been accepted as sort of being tied to our financial lives, and even student IDs used to be social security numbers. We're moving away from using social security number for various IDs, which is probably a good idea. However, we should replace it with what's called a Universal Patient ID, UPI. Now, the federal government has implemented that for Medicare a few years ago, but ironically, since 1999, it has been legislated that CMS does not have funds and is not allowed to work on a universal patient ID. Now, we recently got the Foster-Kelly amendment passed through the House, which would do away with that restriction. It needs to still go through the Senate and be signed off by the president. But hopefully, we're going to be at a point very soon where, on a national scale, that can be worked on again.
So in the meantime, most use cases that need to ID patients need to do something called patient matching. But we know that's not very accurate either. So is that what we are stuck with for now?
Yes, and I think we have a slide on the stats. The numbers are not very encouraging, but they are what they are. And a number of vendors, HIEs, the ONC themselves have been working on getting the match rate up, and with some success. For example, taking the last four of social security number, which is a commonly accepted practice, and I think a lot of use cases use that because it doesn't really expose your social security number whole. Actually get the match rates up in addition to name, gender, and date of birth. But it's nowhere near as accurate and as complete as we obviously wanted it to be.
So is interoperability essentially stuck until we have UPI?
No, it's not stuck. I think in many use cases in healthcare, so patient matching is a reality that's being dealt with, and the sort of match rates are what they are. It helps us. We can still proceed and improve interoperability, but we're not going to be truly automated until we get a universal ID, which means we basically have 100% matching.
Yeah. Well, so we're ending today on an upbeat note after all, and next time we'll talk about a related topic, and that's provider directories. So until then.